طبعا the goal of this lecture, I'm sure I'm not going to give you any new information. You all know that, but we want to rearrange our information so that we will have a clear approach to these kind of conditions. Always, in general, any neurological disease can be tricky sometimes. If you arrange your thoughts, you'll find yourself going faster in your approach. So we'll start right from the beginning. Very basic, the anatomy of the facial nerve. طبعا upper motor neuron, we all know it comes from where? From the frontal cortex, the motor area, up to the nucleus, the main motor nucleus of the facial nerve, which is in the inferior pons. There is this proper facial nucleus, and there's other two nuclei, which are the salivary and the tractus solitarius, for the which give sensory and the anterior 2/3 of the tongue and the tympanic membrane for the sensory part, and for the salivary gland, and parasympathetic, the lacrimal gland. So the unique about the facial nerve in the brainstem is that the nucleus is here, then it goes around, the neuron go around the sixth nerve nucleus and go out together with the sixth nerve and the eighth nerve from the cerebellopontine angle. Then it goes through the temporal bone up to the middle ear. Here is the middle ear. At the angle here is the geniculate ganglion. The geno means bend, because it bends back posteriorly through the middle ear, then goes down to go out through the stylomastoid foramen. Here the styloid and the mastoid body. When it goes out, it gives you the posterior auricular branch, the branch to the posterior belly of the digastric muscle, and nerve to the stylohyoid muscle. Then it goes to the parotid gland, where it gives its main motor branches, the temporal or frontal, zygomatic, the buccal, the marginal mandibular, and the cervical. It's good to know the anatomy before we go on. Another thing, I would like to show you a CT scan. So here we see the brainstem. Here is the nerve going through the temporal bone. And you see the red lines. And here where it bends. So here is the geniculate ganglion. Goes posterior, then inferior, and goes out between the styloid and the mastoid. So this is very helpful if you have an imaging without a report and you just want to take a general look at the facial nerve, there where you can find it. You can see the facial nerve going out easily, going back, and between the styloid and mastoid. Okay, so we'll start with the Dystonias. So as the name implies, the Dystonias are abnormal tone of muscles. So it's a repetitive, prolonged involuntary contractures. We have 4 types: benign essential blepharospasm, apraxia of eyelid opening, hemifacial spasm, and spastic pharetic facial contracture. So the etiology of the benign essential blepharospasm is unknown. They think that it's because of hyperexcitability in the basal ganglia, which give you the abnormal contractures. So the name is benign and essential. So there is no etiology and it's benign. So in most of the cases, or almost all of the cases, no need for imaging. The typical benign essential blepharospasm is bilateral and it disappears during sleeping. So what can mimic a benign essential blepharoplasm is an irritation to the ocular surface that can give you a persistent contracture of the eyelid muscles. So it's not repetitive like in the benign essential blepharoplasm. It's more persistent, and usually the patient have redness and other symptoms of ocular irritation. Only 20% would remain isolated, only blepharospasm. Most of the patients will have involvement of other parts of the face and sometimes the body. If it involves the midface with the blepharospasm, this is what we know as Bruegel syndrome. Bruegel syndrome, where we have also lower face and neck spasm and torticollis. The name Bruegel syndrome came from the artist, Norwegian artist Bruegel, who painted this in the 16th century. They think that this is the first representation of a essential blepharospasm, as you see here, with the eyelid contracture and lower facial contracture. Other types is segmental cranial dystonia, where the patient would have other cranial nerve abnormalities, and generalized dystonia with the involvement of the rest of the body. It was until the 19th century when it was first described in the medical literature. And at that time, they used to injure the facial nerve in order to stop the blepharospasm. But you know, this will clear a problem and create more problems until in the 1980s, when the botulinum toxin was approved for blepharospasm. So the benign essential blepharospasm usually starts with only increased rate of blinking, and then to be more forceful with time. Sometimes it decreased with some hobbies, and even sometimes during the doctor's visit. So it's easily can be missed if you didn't take the words of the patient seriously. So if the patient come with complain of a repetitive contracture of the eyelids, even if during examination he doesn't have it, that doesn't mean that he don't have essential blepharospasm, because sometimes it decreases during the doctor visit. One pathognomic sign, if the patient tells you that it is controlled with whistling, singing, and humming, it happens in 20% of the patient. And if you have it, it's pathognomic for the benign essential blepharospasm. On the other hand, some other activities may worsen the condition, like the reading, driving, sewing, and this can make the patient's life difficult. That's why it's really important to start the medication for the patient before it affects their daily life. It can start asymmetric, but eventually it will become bilateral. And usually, even if asymmetric, you'll see some contracture if you pay attention to the other side. So this is a benign essential blepharospasm. What we see here in the center, both eyelid are going inside and downside because of the corrugated and procerus contracture, is called the Charcut sign. It's important to differentiate it from bilateral hemifacial spasm. In theory, they say that although we don't know the exact etiology, but we know that there is certain trigger that triggers the spasm, and the spasm will cause more, even more contracture. There is some, as we said, abnormality in the basal ganglia, so it cannot inhibit the excitability to the afferent. Almost all patients have photophobia, so with light, the basal ganglia will excite and cause a blepharospasm, and blepharospasm will increase the hyperexcitability in the basal ganglia. This is important. We'll talk about it in the management. Once we mention the benign essential blepharospasm, we must mention the apraxia of eyelid opening, because it's rarely isolated. Most of the time, it comes with the benign essential blepharospasm. The apraxia of eyelid opening is bilateral, intermittent inability to open the eyelids, even with a normal levator function and no squeezing at all. So the usual is that patient with benign essential blepharospasm comes and says that I can't open the eyelid sometimes, even when my eyelids are not contracting. So there is no squeezing of the orbicularis, but the levator function inhibition is still there. Because it happens usually with the benign essential blepharospasm, it is commonly misdiagnosed as failure of the botulinum toxin or a side effect of the Botox. They think that it's side effect of the botulinum going to the levator superioris. It's important to identify it because those patients may have a neurodegenerative disease, can be associated with Parkinson, spinocerebellar ataxia, even with multiple sclerosis and other demyelinating diseases. So all patients benign essential blepharospasm with apraxia, eyelid opening, should be investigated for this disease with imaging and blood investigation. So we go to the hemifacial spasm. Hemifacial spasm is segmental, unilateral, periocular, and/or facial myoclonus. It happens in one side. And usually start periocular, then involve the rest of the side of the face. It can be idiopathic, but commonly there is compression to the facial nerve, either by ectatic blood vessel. The blood vessels usually involved are anterior or posterior inferior cerebellar or vertebral artery, or can be by brainstem mass. So in those patients, careful history and examination is very important because the typical cases, we don't need to image them because mostly it's just mostly it's just an ectatic blood vessel coming in touch with the facial nerve and causing the spasm. But if it becomes atypical, then we should be careful and image him and follow him closely. Facial aberrant regeneration of the facial palsy might look like hemifacial spasm, but you can differentiate it by the careful history. The hemifacial spasm usually exacerbated by stress and anxiety, fatigue, or some voluntary movements. It's in contrast to the benign essential blepharospasm persists during sleep, can be associated with low-pitched tinnitus because of the stapedius muscle involvement. As we said, it's unilateral, but rarely can be bilateral. And in those cases, you can distinguish it by the Babinski sign, where in benign essential blepharospasm, we have the Charcut sign, as we said, where both eyelids are drawn downward and inward, while in the hemifacial spasm, bilateral hemifacial spasm, there is asynchronicity, where one eyelid would go down and the other eyelid will go up. And it's called the Bruegel sign. And usually hemifacial spasm will chronically lead to some degree of ipsilateral facial weakness. So if it is the typical hemifacial spasm, usually you don't need to image. If there is numbness, weakness, or any additional neurological abnormality, then we should do imaging. And the best imaging is to do a combination of MRI and MRA of the head and neck. Sometimes to confirm the diagnosis, you need electromyography, which will show a high action potential, high bursts of action potentials from the muscle involved. At last, we have the spastic peritic hemifacial contracture, where there is a sustained unilateral contracture. It's a sustained, not repetitive like in hemifacial spasm, and associated with mild ipsilateral facial paresis. It rarely happens, but if it happens, it localizes for a pontine tumor or demyelination. So it's very important to differentiate it from hemifacial spasm. If you have a sustained unilateral contracture with ipsilateral facial paresis, think of the spastic peritic hemifacial contracture and image for pontine tumor or demyelination. So as the management is almost the same for all, we'll discuss it once. Always remember first to kill the vicious cycle. As we said, the patient will go into a vicious cycle where the afferent causes hyperexcitability, which we call contraction, and the contracture would be an afferent for more contraction. So we try to remove all the triggers that may keep the cycle going on. It's important to tell all the patients to wear polarized sunglasses for the photophobia. Look carefully at the eye. Any kind of dryness, treat it with the lubricating drops. The mildest blepharitis should be treated. You'll be surprised that this will improve the most of the benign essential blepharoplasm drastically. Then most of the patient will need Botox injections to the involved areas, unless it's mainly the main complaint is in the lower facial or in body spasms. Then oral drugs are the first line of treatment, like anticholinergics and sedatives. For those who are non-responders to Botox injections, or those with apraxia of eyelid opening, they should go undergo the limited myectomy, where we remove all the upper eyelid orbicularis and temporal part of the orbicularis, and leave the inferior eyelid orbicularis. If you find yourself need lower eyelid orbicularis myectomy also, you should wait at least 6 months, because some patients after the first limited myectomy might convert and become responders to Botox. So wait 6 months, try Botox again. If not, go for lower lid myectomy. So we finished the Dystonias. Just want to stress on some points. Imaging only with benign essential blepharoplasm with apraxia of eyelid opening, only in atypical hemifacial spasms, and in all spastic paretic hemifacial contractures. We discussed how to differentiate between hemifacial spasm and bilateral hemifacial spasm and benign essential blepharospasm. One is persists during sleep, which is the hemifacial spasm, while benign essential blepharospasm doesn't persist during sleep. The Charcut sign and benign essential blepharoplasm, while in hemifacial spasm, there's the Bruegel sign. The benign essential blepharoplasm can decrease with whistling, singing, and humming, and can decrease also with some hobbies and during the doctor visit. So we'll go now to the facial nerve palsy. We'll go again to this diagram. It's important to remember that the nerve or the neuron doesn't synapse at the geniculate ganglion. As we said, the upper motor neuron comes from the frontal cortex and synapse here for the lower motor neuron. So an upper motor neuron, or the upper part of the face, usually supplied by both sides, while the lower face only supplied from one side. So upper motor neuron lesion will spare the upper part, while lower motor neuron will cause paresis in both upper and lower muscles of the face. There is a lot of facial nerve palsy because of surgical injury. Regarding our surgeries in oculoplastic, there is some surgical consideration. First of all, you need to know the direction of the temporal or frontal branch of the facial nerve. Here, the tragus of the ear, if you go 0.5 centimeter down, then draw a line to 1.5 centimeter above the temporal margin of the eyebrow. This is the line of the nerve. Another important point is that if you draw a line from the start of the zygomatic arch here to the upper part of the ear, above the line, you'll have the nerve superficial to the superficial temporoparietal fascia, while if you go under this line, the nerve is deep to the SMAS, which is a continuation of the superior temporal fascia, superficial temporal fascia. So this is important during dissection surgery here. You should go deeper to the superficial temporal fascia. If you're above the line and you go down the line, you should go superficial to the SMAS to prevent injury to the nerve. So the most common cause of facial nerve palsy is Bell's palsy. It was reported to be about 75%. It's typically unilateral. The onset within hours to days, peaks usually within 2 weeks, and resolves within weeks or slowly up to 6 months. This is the natural history of Bell's palsy. If it doesn't follow this course, you should suspect something else. It's an idiopathic disease. They think that it has something to do with herpes simplex virus, which causes edema and the intraosseous part of the nerve, which will cause the palsy and the injury. Other causes of the facial nerve palsy: infections, like in Ramsay-Hunt syndrome, where there's herpes zoster infection. Typically, you will find lesions at the external ear, just around the external auditory meatus, and can be accompanied with auditory symptoms and neuralgia. Otitis media also can cause facial nerve palsy. Other infections, less commonly, like Lyme disease, HIV, and leprosy. Inflammatory, like sarcoidosis, Wilkerson-Rosenthal syndrome is a recurrent alternating facial nerve palsy where there is recurrent facial edema, colitis, which is edema of the lips, gingivitis, and fissured tongue. If there is a bilateral presentation of facial nerve palsy, you should suspect Guillain-Barré syndrome or other filter process in the brainstem. So in history and examination, you should ask about the onset, when it peaked, if there is recovery, and if there is recurrence, and if it is unilateral or bilateral or alternating. All these questions will direct you in the differential diagnosis, and most importantly will tell you if it is just a Bell's palsy or something else. Of course, you should ask about history of surgery, and when you come to the part of tearing, you should take a clear history of that before, if it is intermittent or continuous, if it is gestatory related to the eating or not, or if there is dry eye symptoms. A very famous grading system for the facial nerve this will not help you in the diagnosis, but very important to keep follow-up of the patient. It gives you the severity and the dynamic improvement of the case. Grade 1, or let's say if there is any asymmetry at rest, it's either severe or total paralysis, 4 or 5, 5 or 6. There is normal facial function. This is grade 1. If there is only slight weakness while contracting the muscles, this is grade 2. If it is obvious but not disfiguring with normal symmetry, this is grade 3. Grade 4, if there is disfiguring asymmetry during contracture and obvious weakness with still normal symmetry, this is grade 4, which is moderately severe. And as we said, if there is asymmetry at rest, this is severe dysfunction, grade 4, grade 5. And if there is no movement at all, this is grade 6. So as I said, it's very important to keep clear grading for follow-up of the patient during the first 6 months of the palsy. Of course, you should do a careful slit lamp examination of the eye. There's an acronym, BAD, so that you don't forget to check the Bell's phenomena, anesthesia by checking the corneal sensation, and dryness, to check the dryness of the cornea, and the severity of the dryness. You should also check the eyelids, the lower eyelid and punctum position, the strength of the blink, and how frequent, is it poor, fair, or good, and the length of the lag of thalamus. Check for aberrant regeneration, because if there is aberrant regeneration at presentation, that means that this might be a chronic onset facial palsy and deserves good investigation and imaging. Remember, in recording visual acuity in those patients, always make sure that the eye is not covered with a layer of lubricating ointment, because those patients, they don't have, or they have a poor blink, so the ointment would still be there on the cornea, and this will affect the visual acuity strongly. So you can find him to 20/100 if when you remove the ointment, it's 20/40 or even 20/20. So it affects the visual acuity. And always don't forget to examine other cranial nerves, because involvement of other cranial nerves will direct you to brainstem origin, like if in acoustic neuroma or other cerebellopontine angle tumors, you can have cranial nerve 5 and with or without cranial nerve 6. In Bruegel Syndrome, you would have also cranial nerve 6 palsy and pyramidal tract involvement, causing contralateral hemiplegia. And Bruegel syndromes, there will be anteromedial medial portion of the temporal bone tumor, which will cause cranial nerve 6 and 7 palsy. And in Fisher's 8.5 syndrome, you would have involvement of cranial nerve 6 with medial longitudinal fasciculus and the 7th cranial nerve. So when we come to the management, we have temporary measures. This is from the beginning until the resolvement of the palsy, which is from 12 weeks to 6 months. All patients should be on lubrications, preservative-free drops with ointment at night. In children and in those sedated, like in the ICU, it might be a good idea to put a moisture chamber with either eyeglasses or even any form of plastic cup. Put an ointment and tape the glasses tight to form a moisture chamber. You can do taping for the upper lid to the cheek during sleep for the lag of thymus, or even taping the temporal lower eyelid to the lateral, over the lateral canthus if there is ectropion or retraction. And these measures used if there is only mild to moderate involvement to the cornea. If there is severe involvement in the cornea with even maybe corneal epithelial defects and ulcers, you can go directly to more aggressive, go directly to temporary tarsorrhaphy or permanent tarsorrhaphy. You can use external or internal or even internal weight implants. External implants are those that fixed with glue over the upper eyelid. It comes in colors so that it will not be obvious. Or you can use, in very severe cases, when you want the eyelid to be shut completely, you can use Botox to the levator palpebra superioris. You inject this in the superior orbit, like you're given the peribulbar injections. You go 12 millimeter into the superior orbit and inject the Botox there. It will be over the levator, and it will stop it from working directly. This will usually, the Botox will take 12 weeks to go. By that time, inshallah, the facial palsy would be improved already. Then after 6 months, you assess the patient again, and you can go for permanent management, which include, if there is a mainly upper eyelid problem, the lag of thymus and the exposure because of mainly lag of thymus, you can use gold or titanium weight implants in the upper lid. And if there is mainly lower eyelid ectropion and laxity, you can do a lateral tarsal strip with or without tarsorrhaphy. And if there is facial ptosis, you can do a mid-face lift. Sometimes there will be posterior lamellar shortening because of the chronic ectropion and retraction. In this case, you should do also infratarsal spacer. You can use either sclera or even hard pellet graft. You should also check the anterior lamellar if there is anterior lamellar shortening. In this case, you need to do a full thickness skin graft. There is other techniques that have been used during over the years, like area sling, which is a silicone sling that is put circle around eyelids, or palpebral spring. But these have high rate of extrusion and friction. That's why it's not used that frequent. And temporalis transposition, where we transpose the temporalis muscle into the upper and lower eyelid, but it's technically difficult and challenging, so that's why it's not used that frequently. After facial nerve palsy recovery, 70% will recover completely. The rest might have either weakness or can have synkinesis. Synkinesis where the facial nerve branches abnormally and give contraction and the eyelid orbicularis with contracture of other muscles of the face. Or it can also give gestatory tearing with salivatory production. So in these cases, the treatment is to give Botox injections to the muscles involved or the lacrimal gland. For the muscles, I usually give 2.5 units in the medial part and temporal part. In the lower eyelid, 1 unit in the medial part and 2.5 in the temporal. This is to prevent inhibiting the pump. And for the lacrimal gland, usually 5 units will decrease the tearing. Yeah, one more thing I forgot to mention, the epiphora and facial nerve palsy can have a lot of causes. It can be because of dryness, because of exposure. It can be because of retraction and ectropion, so drawing the tear lake away from the punctum. It can be because of punctum ectropium, or it can be gestatory because of the synkinesis. And if all of these are not there, it would be because of pump function failure. So in those patients, epiphora post facial nerve palsy, you should look specifically for these things, correct any malposition of the eyelid, correct the punctum malposition if it's there, correct the dryness. If it is associated with salivation, give Botox injection into the lacrimal gland. And if it's a pump problem, then the best treatment for those patients is the conjunctival DCR or Jones tube. But better not to go directly for it, because you might induce more dryness if you put the Jones tube. So try treating other causes and dryness, decrease the epiphora before you go for Jones tube. And that's it. If there is any question, I'll be happy to answer. we said that the onset should be within days, only maximum 72 hours. The peak should be within a few weeks, and it should recover within weeks up to 6 months. If any of these becomes different, either the peak takes too long or the onset becomes more slow or chronic onset, or there is other neurological deficit, or it persists to progress more than 6 months, then you should be suspicious and image the patient. Is eyelid myokemia considered dystonia? No. Although hemifacial spasm can sometimes start with myokemia only, but it's not the same. Myokemia is only contracture of fibers of the muscle, not the whole muscle. So it's not the same. But hemifacial spasm can sometimes start with myokemia, then become a clear hemifacial spasm.